Hello, welcome to part two, where we're going to discuss coronavirus and cancer considerations. This is a short adjunct to our first longer lecture, where we're going to talk about how coronavirus specifically impacts the cancer population. So, in a Chinese observational study, cancer patients were at higher risk of COVID-19 and did have worse outcomes, although this study was a very small number of patients, 7 out of 18 patients versus 124 of the total cohort, which was over 1,500 patients. But it did look like the fatality rate for cancer patients were higher than the general population. And their researchers recommended intentional postponing of adjuvant chemotherapy or elective surgery for stable cancers should be considered in some endemic areas. Stronger personal protection for cancer patients. So, masks are a good idea, a good extra precaution for cancer patients, especially when they're going for infusion where they also don't want to infect other patients in the infusion room who might be immunocompromised from treatment. And more intense surveillance of patients with cancer, especially those who are old or have other comorbidities. ASCO has really wonderful resources on its website for providers, oncology providers, just reminding us that clinical decisions should be individualized and consider factors like the risk of recurrence if therapy is delayed or modified, that there are some adjustments that could be considered. ASCO includes some patients may be able to switch from chemotherapy IV to oral therapies where appropriate. It is reasonable to modify or withhold chemotherapy if that matches the goals of care for the patient and depending on the treatment course and their tolerance of treatment. If local transmission affects a particular cancer center, reasonable options include giving a chemo break for 2 weeks to separate out the pandemic infections from the cancer populations, or arranging infusions at an unaffected satellite clinic, or arranging treatment at another facility that's totally unaffected. Consider whether home infusion might be an option or feasible for some people. And in some settings, delays or modified adjuvant treatments may pose a higher risk of compromised disease control and long-term survival than in others. So in other words, everyone's going to have to use their judgment call. Certainly, we're working as part of a healthcare team to support the decisions of our medical oncologists. But we can know, and it behooves us to stay on top of what kind of changes might be happening in our more COVID endemic areas. Each of the oncology societies have given their various guidance. So there's links on this slide to NCCN Guidelines. They have a lot of resources. ASTRO, so radiation recommendations, the breast surgeon recommendations, American College of Surgeons, stem cell transplant specific recommendations. One thing overall that is political and important for us to remember is that cancer surgery in general needs to be reclassified as essential versus elective because that will get someone into the surgical suite or not. So there's a unpublished article link there with some doing some advocacy work for cancer patients not to have too many delays, especially with these curative surgeries that shouldn't be happening. Other considerations when we think about coronavirus and cancer treatments are one systematic review basically talked a long time and just said, we don't know. So we don't know how much the immunosuppressive drugs do or don't impact COVID-19. So we'll probably have a better idea in about a year. But we should be aware that there is something called cytokine release syndrome in oncology treatments, especially CAR T. So CAR T has like between a 57 and 100% incidence of this cytokine release syndrome, which very much can mimic cytokine release syndrome from COVID. It can also happen with checkpoint inhibitors. And there are instances, it's not common, but there are instances with other medications like Rituxan and brentuximab and nivolumab. So We need to be especially mindful in our patients with some of these new immune checkpoint inhibitors or monoclonal antibodies that there is this risk of cytokine release syndrome that may play into the equation. ASCO is not aware of data specific to immune checkpoint inhibitors, but it may be appropriate to adjust to less frequent dose intervals when different schedules are considered reasonable options or approved in your jurisdiction. Of particular concern is treatment-related pneumonitis, which may increase the chance of serious complications should the patient develop COVID-19. And that's just a very reasonable warning coming from the ASCO website about pneumonitis. Any of us working with immunotherapies have seen pneumonitis before, so it's not an uncommon side effect and one to pay attention to. And then just an interesting aside is chloroquine and hydroxychloroquine, which is being used for COVID-19 management in some cases, is also sometimes used off-label in cancer care. We have a bunch of hydroxychloroquine trials in melanoma, always combined with other drugs, so it's hard to tell how effective it was on its own. But in glioblastoma and in brain metastases, chloroquine has some promising trials. So that's just an interesting crossover to keep in our awareness. I wanted to just raise a little point when I was in the bunch of studies out of Wuhan, China on COVID-19. It really seemed like Ddimer on admission was increased the risk of in-hospital death. And Ddimer, again, is also associated with other comorbidities like hypertension, diabetes, coronary heart disease, and cancer. I mean, a lot of our advanced cancer patients have elevated D-dimers. It's extremely, extremely common. So, I know that there's so much overlap between these comorbidities and our population, but D-dimer is not a good prognostic variable. And unfortunately, it's high in a lot of our advanced cancer patients anyways. So I've been just making sure that patients are being compliant with their if they're taking blood thinners to prevent pulmonary embolism, Eliquis, are they taking their blood thinners or Xarelto, whatever it is they're taking? Because sometimes people can fall off the wagon with that stuff, and that's really not the time to fall off the wagon. And again, keeping inflammation down aggressively, I think, may make a small dent in D-dimer. So that's something we can continue to think about. When we think about other integrative oncology treatments, there are some cautions. We can make the best decision that we can, and as an educated decision, I would say for mistletoe, there was one cohort study showing that it reduced viral load of Hep C, so it can be used for other viruses, and certainly it's being used in the Lyme community a little bit. But mistletoe does also steer the immune system towards Th2 or eosinophilia a little bit with that with the local raised rash. So please be very cautious and sensible with new introduction of sub-Q mistletoe during COVID. I have a stronger caution to give against IV mistletoe just because you can see cytokine reactions with that. So again, when we're at the height of our pandemic right now, might not be a good time to be doing that. I just encourage people to really think that through thoroughly. I personally am not recommending IV mistletoe right now. And if a patient does develop any new symptoms related to COVID, like a flu or fever or malaise or muscle aches, I'm telling people in advance to please discontinue any mistletoe therapies. Low-dose naltrexone, also a common integrative oncology treatment. I can't find any theoretical reason why not to do it. It definitely steers the immune system from Th2 to Th1, so theoretically could be beneficial, and I can't even think of a reason it could be harmful, so feel pretty good about that. IV vitamin C, I think, and hyperthermia both have potential benefits. So if people are doing IV vitamin C, I do think it's worth continuing their IV vitamin C therapies to the best of their ability. And medicinal mushrooms are more controversial. So we'll talk about that in a longer panel discussion, I'm sure. But overall, mushrooms steer the immune system from Th2 to Th1. Overall, they upregulate the innate immune system, so that initial immune protection. And overall, they tend to be anti-inflammatory, but they do also, many of them, upregulate interleukin 6. So that's where the plot flaw comes, and where there is a theoretical reason not to use them in a more full-blown infection. Just to know about other therapies that generally steer from Th2 to Th1, things that we have seen before. A reminder about some IV vitamin C resources. We have a lovely patient brochure which can be downloaded or printed through the ONC-AMP that talks about safety and key points about IV vitamin C. Again, lower doses are typically used in COVID-19, doses below 25 grams that don't require G6PD enzyme test, but higher doses are often used in the cancer context between 25 grams and 100 grams, and that does require a G6PD test. And next up, we'll deal with integrative support for vaccine.